A lot can change in 50 years. Our second interview with Dr. Larry Brenner, we are going to learn more about the advances in ocular surgery over the last 5 decades and hear a great story about how intraocular lenses were discovered by examining fighter pilots shot down during dogfights in World War II. Dr. Brenner?
I want to talk to you.
Not now, later.
No, now.
We'll switch gears a little bit here. So I heard you tell me that you were practicing general ophthalmology for 30 years and then moved into neuro-ophthalmology, and you've been doing that for you were doing that for how long?
I was a director for 14 years, and then that ended in late 2013, and then I went to a part-time basis when they hired and replaced. When I retired, I was 74, I believe, and I just didn't want to do it on a daily basis, and I didn't feel I had the time or patience to keep up with the volumes of work that needed to be done to keep that up. So I went to a part-time basis, and finally, when I got into my 80s, I think I said that's enough, and then we had COVID hit, and they were very happy not to have an 80-year-old hanging around the eye clinic.
Well, so if we're looking at that, then we're probably 40 plus years that you've been dealing in ophthalmology then, is that correct?
Been dealing in ophthalmology. If we take the start of residency, I've been dealing in ophthalmology for 54 years.
How about that? You know, I think one of the interesting things that's certainly of interest to me is to talk about how the industry has changed over 54 years. And I would imagine that it's changed a lot. I would imagine that there's certain procedures that were done in the past that aren't done now. And I would imagine that there's things that are being done now that may have never even been imagined back then. So maybe you could expand on that a little bit.
That's a great topic because when I started ophthalmology as a resident in 1966, and for the first 2 or 3 years after that, if we take just cataract surgery, which is probably from a volume standpoint the commonest significant surgical procedure done, even to this day, there's hundreds of thousands of patients who get this operation every year in the United States. And when we first did this operation, it was done under general anesthesia because we didn't want the patient to move. We made a large incision in the eye, measured to be 14 or 15 millimeters. We took out the cataract with manual type equipment and closed it with somewhere between 12 and 20 stitches. And when I first did it, they were doing it really with magnifying loops, much the same type of loop you see a jeweler use. And then during that residency, I began to see changes, and I was fortunate to be trained at a time when there was change. The operation changed in terms of removal of the cataract, went to a cryo instrument that was able to actually freeze the lens of the eye and remove it, again through a large incision.
Well, hang on a sec. You're freezing the cataract?
Well, the cataract basically is the crystalline lens, which is just in back of the pupil. And so we dilate the pupil and we put in a solution of those days called Zolice, which loosened the little ligamentous attachments of the lens to the eye. And then we took a cryoprobe, which was about the size of a pen, that delivered liquid nitrogen through the pen and gave you a freezing tip. And then through that incision I described, we're able to attach itself to the lens and sort of what we call dragged it out and hope that not too much else came out besides the lens, which was tricky. So it was a very tricky procedure. And not only the procedure itself, but how we handled the patient during the procedure. We found that patients under general anesthesia would often buck, we called it, on the tube placed down their throat. And so that was not good for cataract surgery. So we decided to give them a light intravenous anesthesia that would just put them into a twilight zone and give them local anesthesia by injecting Novocaine around and back of the eye. That's worked very well, and for the most part, that's still the way it's done. they've now been able to replace the injection with topical drops to numb the eye, but it's all done under local anesthesia with a little general assist. No more general anesthesia. The patient in the early days had to stay in the hospital for a week or 10 days. A lot of people remember they were put in sandbags, so we didn't want them to move. So they'd be laying in bed with their head in rather still position. All of that's changed today. The 12 to 14 millimeter incision has been replaced by a 2.7 millimeter incision. It's done with the cataract is removed with an ultrasonic tip, the size rather than of a pen, but rather of a small pencil. Again, through that 2.7 millimeter incision, it actually grinds up the lens of the eye and then sucks it out. And then through that same incision, an artificial lens is put in the eye to replace the lens taken out, again through that small incision. And it can be closed with either no sutures or one suture. And the patient may get up immediately, goes home that same day, and many of them achieve excellent vision within the first few days.
Good. You know, that's very interesting to me to see how much things have changed. I mean, 50 years sounds like a long time, but it's really not in the grand scheme of things. And to see how much we've progressed from what you were talking about, where you're in the hospital for a week, whereas most of the time cataract surgeries now are done outpatient, I believe, right?
Absolutely, absolutely. I think one of the interesting stories that I do best remember is a lot of people wonder, how do we come about having intraocular lenses? We place lens in there. The patients in the early days, before we had them, and we didn't really have them. I was fortunate to do the first one in Houston, Texas in 1973, but they were done in Europe in the 60s. They were done in Florida, where I trained, in the late 60s. But it was discovered by an ophthalmologist in London who examined many of the RAF pilots who were shot down over the Battle of Britain in World War II, and who, as a result of having had the cockpit windshield explode during dogfights, that many of them will have intraocular foreign bodies of this material. It would get in the eye, and it was very dangerous to try to remove them. But many of them would go on for years with these small little fragments in the eye, and the eye handled it very well. It didn't seem to reject it. So it came about, well, why can't we put an artificial lens in the eye made of the same stuff? And in fact, the first lens implants were of this perspex, or methyl methacrylate is what it is, into the eye, and that's the first ones I put in. Today they use other synthetic materials that are even more compatible, much softer. You can fold them through that small 2 millimeter incision. So, but the basic idea of a lens implant came about because of World War II and a very smart English ophthalmologist by the name of Ridley.
Well, and how did you feel about that? You know, as a professional a professional, when somebody comes to you and says, "Well, look, we can take these lenses and we can stick them in the eye." What were your thoughts when you first heard that?
I didn't have any negative thoughts because it was already established that it could be done. The actual first lens implant placed in the world was in 1949, but I didn't have too much worry about that. I accepted the medical's opinion that this was a safe thing to do. The materials were different than we use now. They were larger. They didn't fold. We had to put them through bigger incisions. A lot of different things had to go on with the eye. Cataract surgery was a much bigger thing. And the average ophthalmologist who's really busy could do maybe 3 or 4 of this procedure in a half a day. Today, the very busy, active cataract surgeons can do 12 to 15 operations in half a day. And they could take maybe 20 minutes to 30 minutes per operation. So it's a different, refined procedure, not just good for the ophthalmologist, but most important, best for the patient. And the return, many patients have 20/30 vision the first day in the doctor's office. The next day is when they see them. It's a marvelous operation.
It's actually interesting too, because so you were talking about that in the past when people would come in for these surgeries that they could be out for a week. And I would imagine that when that was the case, that a whole lot less people were actually opting to have said surgery. And so at that time, would people just live with these cataracts? Is that the way it would work?
They did. And in fact, if you went to many of the second and third world countries, you had millions of people who had cataracts, and most of the cataract surgery research from a surgical standpoint was done in India and in Africa, where you had people would just walk in and people would be 70 years old and have had cataracts for 40 years and were brought in by their family. Cataracts, blindness due to cataracts is an unnecessary event. And in America, it's gone way in the other direction. Now if your vision's 20/25 and that street sign's a tiny bit blurred, you want it fixed. So the demands of the current patient is entirely different than it was when I started my residency.
Well, and I think there's a big difference there too, where like you said, back then it was, I've got a cataract, I cannot see at all, right? And nowadays it's like, well, not only can we get rid of the cataract, but we could probably make your vision better than it even was before.
Yeah, almost saying that. And if you realize back then, before we had lens implants, the only way you corrected their vision was either wearing contact lenses, which were thick and large and patients often hated, or wear very thick glasses. And some of you may remember a grandmother or grandfather or great-grandfather who wore cataract glasses, and they were very similar looking to a Coke bottle.
I've seen those before. I never knew what they were, honestly. Like I have seen those, you call them the Coke bottle frames, and I've seen some old movies where they have those real thick frames on there, but I didn't know that's what they were for.
Exactly. It was awful. Having cataract surgery was only half the battle. The other battle was finding a way to see with your new vision. And by the way, whenever you wore these Coke bottle cataract glasses after surgery, everything was magnified 30%. So it'd be suddenly, if your whole world was magnified 30% and you were walking around in it, much less driving in it, you could imagine how much accommodation your body would have to do.
Very good. Well, Dr. Brenner, I won't take up too much more of your time, but I think probably one question I think that would be good for a closing question for us is, what is the most exciting thing that has come in ophthalmology in your tenure of doing ophthalmology? What would you say is the one technology that you think was perhaps the most interesting, or maybe the most game-changing, so to speak?
Well, there's so many, because, and again, this is not to sound immodest, but ophthalmology has been at the forefront of most important new things in terms of restoring vision. I think that from a neuro-ophthalmology standpoint, the availability of medications, of drugs to treat severe problems has really been, particularly the use of antimetabolites, antibody treatments. I think that's been the big thing. From an ophthalmology standpoint, I'd say cataract surgery one and LASIK surgery, where the huge number of patients who had high myopia and astigmatism could now be corrected with surgery without having to have a lifetime of glasses and contact lenses.
Well, Dr. Brenner, thank you so much for being with us today. I hope that we can get to have lots more of these discussions, and I look to have you on the show again real soon. So thank you very much for being with us.
My pleasure. Thank you, Thomas. Take care.